Welcome to this presentation, which will focus on genetic factors in treatment-resistant depression. As you probably know, genetic research was much increased in recent years, and results are coming. And this will be the object of this presentation. We all know that treatment-resistant depression is not a single entity. Is quite complex to define. Indeed, in the last decades, there were so many definitions of treatment-resistant depression. Patients that don't respond to the single treatment or to treatment, to different classes of antidepressants, and so on. As you can see in this slide, indeed, the clinical reality is quite complex. You can have patients that don't respond at all since the beginning, and this is clearly treatment-resistant depression. But you can also have patients who start to respond and then they don't respond anymore, or they show a worsening at the beginning and then they respond later. This is why it's complex to work with treatment-resistant depression. But genetic factors can be of help for us, for clinicians. Indeed, in this newspaper, it was reported a few years ago that this woman had a very big help from genetic findings. She was suffering from depression and she was administered many antidepressants, all of them without any benefit. And so it was a very clear-cut case of treatment-resistant depression. And then she underwent to genetic testing, and the result of the test suggested to use another antidepressant that was not being used before, amitriptyline in a specific case. And it worked. And therefore, there was a big discussion in the general press and scientific world if really genetic is starting to be very helpful also for us and for our everyday clinical practice. However, this is a single case, and as we know, single cases don't create science. And indeed, the reality is quite more complex, as we will see during this presentation. Let's start from simple things. The most simple thing is to use the genes that modulate and control the drug metabolism, the so-called pharmacokinetic, pharmacogenetic. And this is already well established. The two major organizations that describe this aspect of pharmacogenetics, CPAP and the Dutch working group, they both are very concordant, suggesting that for some patients, pharmacogenetic, it would be extremely useful. At least for the part where we control for our liver enzymes genotype. As you may know, some of us are poor metabolizers. That means that we don't metabolize properly the drug and we need a lower dose in order to avoid side effects, and other subjects are rapid or ultra-rapid metabolizers, and therefore they need higher doses for treatment. And this is well, as I told you, very well established by now. So well established that, as you can see in psychiatry, we have more than 30 compounds that have in the label the suggestion to use the pharmacokinetic genetic determinants to see if our patients are poor metabolizers or rapid metabolizers. And our field is second only to oncology with suggestions to use this kind of genetics. And that the metabolism of antidepressant is important is very clear, and we confirmed it recently with a series of papers. This is just one about duloxetine, where we see very clearly that if our patients have too low a concentration of the antidepressant in their blood or too high concentration of the antidepressant in the blood, we have a poor response. And this is a very simple phenomenon, can lead to treatment-resistant depression. And therefore, to summarize this first easy part of the pharmacogenetics of treatment-resistant depression, we can hypothesize that a subgroup of our patients, 10–20% of our patients, they have a different genetic background for their metabolic liver enzymes. and therefore they have a different plasma level that can be too low or too high. And therefore, the suggestion is that when we see non-response to a first-line treatment, then it's very appropriate to test for the genetic structure of the liver enzymes of our patients. And therefore, we can see if they are so-called extensive metabolizer in green, normal metabolizers, and then we use the usual clinical criteria for changing drug, switching, and so on, or potentiation. But if they are ultra-rapid metabolizers, then we need to increase the dose up to double sometime, or if they are poor metabolizer, we should decrease the dose. And this way, we can somehow reduce the rate of treatment-resistant depression in a genetically driven way. But after the easy part, let's go to the more complicated one. That is the genes that control our brain. So the so-called pharmacodynamic pharmacogenetic. Our brain is not the same across individuals, and there is a huge number of variations, millions of variations that shape the neuron activity, the neuron functionality, and so on. And this is the largest and most important and most interesting part that can modulate why some of our patients become treatment resistant. It was more than 20 years ago when we for the first time saw that a single gene serotonin transporter with a variant that modulates the functionality of the serotonin transporter protein was very clearly associated with antidepressant response. At that time we were extremely happy, thinking that we discovered the reason and the cause for treatment-resistant depression. The difference was quite high. Unfortunately, after 20 years of research, this result reduced a lot its importance, and at present is not so strongly suggested as a modulating factor. Single gene out of more than 20,000 genes is quite unlikely that can have a broad effect on treatment-resistant depression. It may have a small effect, but not a broad or large effect. This is why in recent years research shifted to what is called genome-wide studies, where all the genome is considered at once. We did it, other people did it. Here you can see that is posted in medRxiv, the most recent genome-wide study, including thousands of patients, that demonstrates that indeed there is an effect of genes on remission and response. Even if it's not strong, but is there is an effect, but it's quite distributed across the genome. So it's not a single gene, but it's the combination of many gene variants that shape different combination of proteins and functionalities in our brain that can give the liability for treatment-resistant depression. And indeed, the reason why genetic is important in treatment-resistant depression are quite known since many years. Studies from the 90s or the 80s even suggest that there is a strong familial aggregation in the quality of response to the treatment. And also meta-analysis and genome-wide association studies give signals. Therefore, something is there. The only difficulty now is to define exactly which are the factors distributed across the genome that modulate treatment-resistant depression. And if single genes or even genome-wide analysis are not sufficient, in the recent times, all researchers, including us, shifted to the analysis of the whole genome sequencing or exome sequencing, where all the variants in genome are completely known, sequenced, and therefore not only candidate genes or sparse signals like genome-wide analysis. And an example of this kind of research and the possible potentiality that are inside this kind of research is in this quite recent paper where we, in over 1,000 patients, responders, non-responders and treatment-resistant depression, we investigated the sequence of the whole exomes of those patients. And indeed, there were differences, not going into detail in terms of the methodology that you can read in the paper if you are interested. The results were pointing to systems that are quite known from other fields of research to be involved in treatment-resistant depression. For example, the system of neuroplasticity. We know that response to antidepressants is somehow modulated by the response and the plasticity of the pathways involved with depression, and to the system of stress and inflammation. And when we combine all the information coming from these pathways, from these single signals, many signals across the sequencing of the whole genome, we see that combining all this information and combining also with clinical variables, we see that the prediction is relevant, a prediction that can also be somehow useful in clinical practice. This is a standard ROC curve. As you can see, the prediction is far from perfect, but is significantly better than chance. And to clarify to clinicians how this system works, I'm showing here this paper that has been published recently by us, where you can see in the table what is exactly the scores that we are using to define a possible treatment-resistant patient. You can see that subject 1, 2, 3 to 6, they have different scores in their different paths. Scores that means the risk of having a pathway that is liable for treatment-resistant depression. For example, you can see that in the first subject, path 1 is a score of 3. That means a very high score. It means that this path could be a path for neuroplasticity, is very, let's say, bad for depression. The pathway of neuroplasticity is not sufficiently, for example, plastic, so cannot change quickly after antidepressant treatment. Same as path 2, path 3, and so on, and totaling for a genetic liability of 0.99. It means that this patient is genetically liable for treatment-resistant depression. And then we should combine it with the clinical predictors. It means that, for example, this patient is unemployed with no social network, and therefore leading to a total 1.58. That means that this patient is indeed a quite high risk for treatment-resistant depression. You can see the opposite, for example, patient 3, that has a very favorable profile, genetic and clinical, totaling to a minus 2.64. That means a protective score, both genetic and clinical. In this way, we can define subject by subject the risk of treatment-resistant depression, combining genetic and clinical variables. And as you can see in the bottom, this can lead also to calculation of cost-effectiveness treatment. For example, a patient that is very, let's say, unfortunate and lucky with many pathways leading to the negative direction can be treated with combination, for example, pharmacotherapy and psychotherapy since the beginning, or a different pharmacotherapy combination since the beginning to avoid treatment-resistant depression. And the benefits of using these composite scores in treatment-resistant depression are starting to appear. For example, in this very recent paper that we published on molecular psychiatry, we used the so-called PRS, polygenic risk scores. In this case, they are not from exon sequencing, but from Genomewide. And we saw that indeed these scores are quite useful in predicting severe depression in the general population. Here we are talking about the very large sample of the UK Biobank, and we studied more than 30,000 patients. And therefore, it seems that this effect of scores predicting treatment-resistant depression is indeed achievable. But not only, because, okay, that the score can be useful for predicting treatment-resistant depression, but we are much more interested in using the score to guide our treatment. And in this extremely recent paper that we just published, we studied exactly this question in our sample of treatment-resistant subjects. And in this sample, we saw two very interesting findings. The first is that the score, the polygenic risk score for schizophrenia, it means the combination of signals from the genome that give the liability to schizophrenia, are indeed associated with the risk of treatment-resistant depression. The more you have this kind of polygenic risk score, the more you have the risk for treatment-resistant depression. But this is the much more interesting finding of this analysis, that this score that is not only predicting treatment-resistant depression is also suggesting specifically which treatment we should use. So we are talking among treatment-resistant patients, we have subjects with high PRS for schizophrenia and subjects with low PRS of schizophrenia. And we saw that the benefit of treatment is different, and is interestingly in a logic direction. If a patient has a very high PRS for schizophrenia, and when we use the augmentation with atypical antipsychotics, we have a small benefit. And this is what we expect usually when we combine atypical antipsychotics in non-responding patients. But we see much more interesting in the other part of the slide when we see that in patients with low PRS of schizophrenia, the augmentation with atypical antipsychotics is giving no benefit at all. So it means that those patients probably do not have the biological substrate to benefit from atypical antipsychotics. And so, in other words, atypical antipsychotics could be a good add-on therapy, combination therapy for resistant patient only if the patient has a background genetic of schizophrenia, even if not clinical schizophrenia, just a subthreshold genetic predisposition. And this leads to a possible future, a future that we can describe a patient on the basis of their score, of their genetic score, polygenic risk score. For example, in this figure, you can see that a patient can be in the high distribution of the polygenic risk score for schizophrenia. This is the case of bipolar patient, average distribution of bipolar disorder, and low distribution for major depressive disorder risk score. Clinically, the patient is bipolar, but the genetic background is specific of this patient. And of course, to this patient with a high polygenic risk score of schizophrenia, even if without schizophrenia, then it is indicated to use second generation antipsychotics, atypical antipsychotics. If the polygenic risk score for schizophrenia would be low, then probably the indication would be much more for lithium or mood stabilizers. So you see how the future could give our patients a composite score based on the risk of the different psychoses in our brain, and therefore guiding the choose of the specific treatment for the patient. And not only, because this kind of score studies, genetic score studies, could profile our treatment-resistant depression to be more sensible also to compounds that are not routinely used for depression. In this other very recent paper, we saw that, for example, specific genetic profiles could benefit from compounds and drugs that are not commonly used for depression. But this is yet an experimental perspective. And therefore, I completely agree with this editorial in Nature a few years ago that this is time for one-person trial. We are different one from another on so many different aspects, genetic, clinical, and therefore it's important that we don't standardize treatment for all patients, but we try much as possible to be specific based on the evidence that we are starting to have now. In specific, what I can imagine that we can use to solve the problem of resistant depression in the future is to use a combination of score coming from genes or imaging or blood markers that profile exactly our patients combined with clinical features and their patient need. In this way, we could find much more easily the right treatment for every patient, considering that we can use more than 100 compounds, and it's quite difficult to try all of them one by one, of course. And so the question is now, are we ready to use the pharmacogenetic testing in everyday clinical practice? There is another presentation that you can see that is specific tailored for this question, but just a few words to say that those kits are already available. There are so many available in all countries worldwide. But all major societies, including me, suggest much caution in using those kits because probably the ones that are already available include only a small number of gene variants. As you have seen in my presentation, is probably the answer is in the score of many variants that are combined across the genome. So the use of only 5, 10, or 15 variants probably is not sufficient to give a reliable prediction. We also published a paper about this. Final point, I suggest much caution in using the recommendation coming from the genetic testing that are available at present in the market. And so, going to the conclusion of this presentation, again, this news of Alice, this depressed woman that after trying about 40 antidepressants, then she found the right one thanks to genetic testing. Yes, but this was a specific, very lucky case. This is not the rule. We should know that genetic for sure will be of great help in the future, but at present still we must be very cautious. I'm not the only one saying this. For example, this is another paper suggesting that in the race of the use of genetic testing, science maybe is left behind. We should always consider the scientific finding rather than the marketing promises. And this is the last slide of this presentation that summarizes the content of this presentation. As you can see in this recent published paper with Dr. Fabri, we are trying to give clinicians the indication about what to do from a genetic proper perspective. Well, first, we should always start from the individual symptom profile. When we prescribe an antidepressant or combination of treatment, we should always consider the pharmacodynamic properties of the compound and the symptomatology of the patient. A very simple example, if a patient has a typical depression or too much sleepiness, we should not prescribe mirtazapine. And the opposite, if a patient is very anxious and not sleeping, we should not prescribe bupropion. And therefore, this is the first step that we all clinicians do to match the individual symptom profile of the patient with the specific treatment. But this sometimes is not sufficient, and then we are in the situation of treatment-resistant depression. So, even if after the usual choice of the antidepressant, we don't reach the response that we want to reach, we are in the treatment-resistant depression. And then here, second step is strongly suggested to use the genetic testing. And this is not only my opinion, it's the opinion of all the major scientific companies, associations worldwide, and it is also in the label of many antidepressants. Genetic testing that should do what I call easy part, test the pharmacokinetic genetics, so how the patient is metabolizing the drug. And then we can have patients who are poor metabolizers. In this case, we have to reduce the dose in order to avoid too high plasma levels leading to side effects. Or we can have another 10% of patients who are ultra-rapid metabolizers, and then in this case, we have to increase the dose, 50% or sometimes also 100%. Otherwise, the plasma level is too low and the compound is not reaching its target. And then, if this doesn't work, there will be This is why we put it in gray. There will be, because it's not still there, the use of PRS, polygenic risk scores, the combination of scores, combination of scores of many variants across the genome, hundreds of thousands, coming from genome-wide studies or coming from exome sequencing studies or coming from whole genome sequencing, that give the profile, exactly the profile of the patient. You have seen the case that sometime some evidence there is there that with a high polygenic risk score for schizophrenia, if the patient is affected by depression with no clinical sign of schizophrenia, but with a polygenic risk score of schizophrenia, there is an increased risk of resistant depression. And not only, there is also specific indication that those patients may benefit more of the combination of the antidepressant with atypical antipsychotics. So while patients with low polygenic risk score of schizophrenia don't benefit of this combination. And this is the first example of a very clear indication for clinicians. However, presently available genetic kits in the market are still far from perfect. So I suggest much caution in using them at present. Probably in the future we will have many more possibilities. Thank you for your attention.